Hello, my dear friends. It's my pleasure and great honor to share with you this very important lecture about what's new in ESC guidelines for management of atrial fibrillation. I will try to summarize the most important new recommendations in about 12 points. Let's start with recommendation for screening to detect AF. When screening for AF, it is recommended that the individuals are undergoing screening are informed about the significance and the treatment implication of detecting AF. A structured referral platform is organized for screen positive cases for further physician-led clinical evaluation to confirm the diagnosis of AF and to provide an optimal management of patients with confirmed AF. Definite diagnosis of AF in screen-positive cases is established only after the physician reviews a single lead ECG recording of at least 30 seconds or 12 lead ECG and confirms that it shows AF. What about the recommendation for prevention of thrombo embolic events in AF? Stroke and bleeding risk reassessment at periodic intervals is recommended to inform treatment decision, such as initiation of oral anticoagulation in patients no longer at low risk of stroke, and address potentially modifiable bleeding risk factors. For a formal risk score-based assessment of bleeding risk, the Hasbled score should be considered to help address modifiable bleeding risk factors and to identify patients at high risk of bleeding with Hasbled score of 3 or more for early and more frequent clinical review and follow-up. In patients with EF initially at low risk of stroke, first reassessment of stroke risk should be made 4 to 6 months after the index evaluation. Estimated bleeding risk in absence of absolute contraindication to oral anticoagulation should not in itself guide the treatment decision to use oral anticoagulation for stroke prevention. Clinical pattern of AF either first detected, paroxysmal, persistent, long-standing persistent, or permanent should not condition the indication to thromboprophylaxis. What about recommendations for cardioversion? Pharmacological cardioversion of AF is indicated only in hemodynamically stable patients after consideration of thromboembolic risk. For patients with sick sinus syndrome, EV conduction disturbances, or prolonged QT more than 500 milliseconds, pharmacological cardioversion should not be attempted unless risk for proarrhythmia and bradycardia have been considered. What about the recommendations for rhythm control or catheter ablation of AF? For the decision on AF catheter ablation, it is recommended to take into consideration the procedural risk and the major risk factor for AF recurrence following the procedure and discuss them with the patient. Repeated pulmonary vein isolation procedures should be considered in patients with AF recurrence, provided the patient's symptoms were improved after the initial pulmonary vein isolation. AF catheter ablation for pulmonary vein isolation should be considered for rhythm control after one failed or intolerant to beta blocker treatment to improve symptoms of AF recurrence in patients with paroxysmal and persistent AF. AF catheter ablation for pulmonary vein isolation should or may be considered as a first-line rhythm control therapy to improve symptoms in selected patients with symptomatic paroxysmal AF episodes as a class 2A recommendation, or persistent AF without major risk factors for AF recurrence as an alternative to antiarrhythmic drugs, considering patient choice, benefit, and risk as a class 2B recommendation. Use of additional ablation lesions beyond the pulmonary vein isolation, such as low voltage areas, lines, fragmented activity, ectopic foci, may be considered but is not well established. Strict control of risk factors and the avoidance of the triggers are recommended as part of rhythm control strategy. What about the recommendations for stroke risk management peri cardioversion? It is recommended that the importance of adherence and persistence to NOAC treatment both before and after cardioversion is strongly emphasized to the patient. In patients with AF duration more than 24 hours undergoing cardioversion, therapeutic anticoagulation should be continued for at least 4 weeks, even after successful cardioversion to sinus rhythm. Beyond 4 weeks, the decision about long-term oral anticoagulant treatment is determined by the presence of stroke risk factors based on the CHA2DS2-VASc score. In patients with definite duration of atrial fibrillation less than 24 hours and very low stroke risk, CHA2DS2-VASc score 0 in male or 1 in female post-cardioversion anticoagulation for 4 weeks may be omitted. What about the recommendations for stroke risk management peri-catheter ablation? In AF patients with stroke risk factors not taking oral anticoagulation before ablation, it is recommended that the pre-procedural management of stroke risk include initiation of anticoagulation and, preferably, therapeutic oral anticoagulation for at least 3 weeks before ablation as a class 1 recommendation, or alternatively to use the transesophageal echo to exclude left atrial and left atrial appendage thrombi before ablation as a class 2A recommendation. For patients undergoing AF catheter ablation who have been therapeutically anticoagulated with warfarin or NOACs, the performance of ablation procedure without oral anticoagulation interruption is recommended. What about recommendations for long-term antiarrhythmic drugs? In AF patients treated with sotalol, close monitoring of QT interval, serum potassium level, creatinine clearance, and other pro-arrhythmia risk factors is recommended. In AF patients treated with flecainide for long-term rhythm control, concomitant use of an AV nodal blocking drug, if tolerated, should be considered. Sotalol may be considered for long-term rhythm control in patients with normal left ventricular function or with ischemic heart disease if close monitoring of QT interval, serum potassium level, creatinine clearance, and other pro-arrhythmia risk factors is provided. What about the recommendations for lifestyle interventions and the management of risk factors and concomitant diseases in AF? Identification and the management of risk factors and concomitant diseases is recommended as an integral part of treatment in AF patients. Modification of unhealthy lifestyle and targeted therapy of intercurrent conditions is recommended to reduce AF burden and symptom severity. Opportunistic screening for AF is recommended in hypertensive patients and should be considered in patients with obstructive sleep apnea. What about recommendation for patients with AF and acute coronary syndrome? In AF patients with acute coronary syndrome undergoing an uncomplicated PCI, early cessation of aspirin after 1 week and continuation of dual therapy with oral anticoagulation and P2Y12 inhibitor, preferably clopidogrel, for up to 12 months is recommended if the risk of stent thrombosis is low or concern about bleeding risk prevail over concerns about risk of stent thrombosis, irrespective of the type of the stent used. What about AF with chronic coronary syndrome? After uncomplicated PCI, early cessation after 1 week of aspirin and the continuation of dual therapy with oral anticoagulation for up to 6 months and clopidogrel is recommended if the risk of stent thrombosis is low or concerns about the bleeding risk prevail over concerns about the risk of stent thrombosis, irrespective of the type of the stent used. What about recommendations for management of active bleeding on oral anticoagulation? 4-factor prothrombin complex concentrate should be considered in AF on vitamin K antagonists who develop a severe bleeding complication. What about recommendation for management of atrial fibrillation during pregnancy? In pregnant women with hypertrophic cardiomyopathy, cardioversion should be considered for persistent AF. Ebutilide or flecainide intravenously may be considered for termination of AF in stable patients with structurally normal heart. This is as regards the acute management. What about the long-term management? Flecainide, propafenone, or sotalol should be considered to prevent AF if AV nodal blocking drugs fail. Digoxin or verapamil should be considered for rate control if beta blocker fails. And finally, what are the recommendations for postoperative atrial fibrillation? Long-term oral anticoagulation therapy to prevent thromboembolic events should be considered in patients at risk for stroke with postoperative AF after non-cardiac surgery, considering the anticipated net clinical benefit of oral anticoagulation and the informed patient preferences. Beta blockers should not be used routinely for prevention of postoperative AF in patients undergoing non-cardiac surgery. Thank you so much.